to present on acute trauma for the neck and back. I'm going to let him introduce himself, but I do have to remind you that he's been with us for a couple years now. I think this is the second time he's presented to you all. And Dr. Smith is a Fort Wayne resident. He was at Fort Wayne in the Fort Wayne Orthopedic Residency Program back when we had that. And we had our eye on him back then because he's just wonderful. And we've enjoyed having him work with us, so I'm going to turn it over to him.
Thank you. Afternoon. As I was saying, so I was a resident here in Fort Wayne. We had a big program. Then I finished my training out of Stanford. So I went out to California, and despite how nice it was out there, I still came back to Indiana. I did a year of training for fellowship training in spine surgery at the University of Utah in Salt Lake City, which is also a great opportunity. I actually worked half my time with neurosurgeons there and half my time with orthopedic surgeons there. So I kind of had a split mixture of how to kind of address this, several pathology I have, perspectives on that. So today's talk is going to be very informative, or very casual, but hopefully very informative for you. I have a couple of key videos, and we'll basically kind of go down the line and start from the top and work all the way down. So we'll start with some cervical spine injuries, then do thoracic and lumbar stuff. And feel free, if you have any questions, you can save them to the end, or in the middle while I'm talking, go ahead and raise your hand. We can kind of discuss it in there. So when we first start looking at the spine, we kind of look from the top down, and at the very top you have the C1-2 articulation, and then you want to be able to see all the way down to T1, so that's what your normal x-ray is at. If someone comes in with a neck injury in either the ER or our office, that's what we'll be able to see to really fully assess our pathology. And then the second thing we look at, actually even though it's an x-ray, is we look at their soft tissues, because you can tell a lot in the traumatic setting. They'll give you an idea if there's any bad ligaments injury just on a simple x-ray. You can see a lot of bad things by just looking at that. And then we want to look at our overall alignment. And essentially what we're looking at is to see if the front of the spine all lines up, then the back of the vertebral bodies, and then this line back here, see if that also lines up. And sometimes you see step-offs, and this is where you'll see where things kind of extend and things just don't line up in the natural normal arm. And then we look up here at the very top and make sure that the C1-2 articulation is right. And then right here at the base of the skull, with the spine and the skull attached, we'll make sure those articulations also line up. And basically these are the bodies of the vertebral body. And then this is what we call the facet joints, or lateral masses. So sometimes you'll see on either an opera report or something like that, that they're talking about a lateral mass fusion. So in the cervical spine, this is exactly what they're trying to do. So they're putting screws in there that these are the areas that they're fusing in the back. And then we'll make sure that the spinous processes in the back also line up in a nice normal line. So this is actually my 4-year-old, or he was 4 at the time, now he's 6. And he thought he was going to show off while he was skiing, as he's pumping his arms and doing fist pumps. And then he'd only been skiing at this point for 2 months. And okay, well he didn't fall that time. But so looking at C2, which is what we call it a time weight. This is a specific case where there's just a 61 lady who fell, and she didn't have any neurologic injury, but sometimes you'll often hear about the Denton fracture. This is typically where we see them, and this is kind of the spike of C2 where it goes in and fits basically into the ring of C1 and kind of articulates like this. And this is where you're where you get most of the motion between your head, neck, side to side. And so this lady actually fractured right in through here. And sometimes we treat these in the collar, and sometimes we do surgery. And it really depends on where it's broken and if it's displaced. And right here, where it's broken through here, this is the hardest place for this bone for it to heal without any surgical stabilization. So for her, we actually went in and put screws that went up all on the whole axis of the bone to hold it in place. So most of the time, since these are high up in the spine, usually not associated with any sort of neurological injury. So this is one of those ones that it's generally safe. You know, you kind of say, great. Didn't, you know, you broke your neck, but you know, you shouldn't have any neurologic issues with this. The ones that go a fraction of the way up in the very tip, these are the ones that we typically just treat with brace or collar. And the ones that kind of really break into here, these are also the ones that we fix into a collar or fix with a collar. But the ones that are right at this base, those are the ones where the blood supply comes from here. And so anything that comes, you know, breaks in through there, they usually go on to not fuse, and they have a bunch of soft tissue in there that's still unstable. And so we've learned over the years that these need to be fixed surgically. So in this case, we put these two screws in to hold it in place. Other times we just end up doing a fusion, going from the back of the neck and fusing it. Kind of dealer's choice for those. Otherwise, we usually get people into a cervical collar for 3 months. Sometimes we put in patients in a halo. The only problem with putting, especially with elderly patients, so in general, kind of the cutoff in the literature is 65 years of age. That's when basically there's a high mortality in kind of putting somebody into a halo, not letting them use their neck, and they end up with a lot of respiratory issues and stuff. So they try to avoid it in patients over the age of 65. So this is another injury high up in the spine. The guy, ironically, was working on the top of the public safety building and fell. And you can see here, he kind of broke the ring of C1. And typically there's ligament that comes right through here. And so usually, if you break this ring, as long as this ligament isn't torn, then it's pretty stable, you don't have to do anything for it. But as you can see, if you look real closer, there's these little flecks of bone here. And basically that's telling you he's pulled off that ligament from the attachments of where it attaches to the bone. So this is going to be a very unstable injury, unfortunately for him. If it's intact, and what we oftentimes do, we look to see if there's a lot of splaying apart between this bone and this bone. And so if it's not split apart, then you can just treat them into a collar, and they'll heal fine. And it shows like here that basically these other ligaments here pulled off. So he's got a very unstable injury. This is actually where it attaches to his skull. So his injury not only broke apart, that ring that holds his top of his neck, but then the ligament connections to his skull was also disrupted. And to put things off even more for him, thankfully we got a CT scan looking at the arterial anatomy, and basically he has got this artery where normally we'd put screws in here and here. He's got a big artery sitting right there, which for him could have been catastrophic if we got in there. So for him, we actually had to go and fuse all the way up to his skull. And then we put screws down in the C2 and the C3 and left that area around C1 completely alone. But then that meant for him that he's basically not ever going to be able to move his neck up or down the rest of his life. So this is my 7-year-old son, who's now going to be 9 on Wednesday. He's going a little bit faster. And is obviously a little bit more adventurous. But he keeps coming. So, living out in Utah, we got to see a fair amount of ski injuries. And this is probably one of the luckiest guys alive, because one, he's 42 years old, he's a billionaire because he owns all the slot machines in Las Vegas. But he wasn't smart enough to stay off the double black diamonds when he hasn't done anything more than a blue level ski in his life. So his friends talked him into doing something he probably shouldn't have been doing. And as you can see, he basically took a long tumble, and you see these, obviously these lines that we look at in the spine, some early don't line up, both the front and the back, and then these joints here also aren't lining up. So he literally dislocated his spine, basically completely took his spine up and jumped it over those joints that I was showing you guys earlier. And for him, like I said, he's the luckiest guy alive because he had no neurologic injury. the majority of the time these are associated with at least some sort of neurologic injury. So in order to take care of this, we literally have to put his head and put these what we call tongs on. Those are those big pin things you oftentimes see. And then we had to start hanging sequentially more and more weight off of the back of the bed to get his neck reduced. So now you can see everything's pretty much in line. Just a little bit of a step. So you can see that he had, you know that he had an injury there, but everything's lining up well. And then we go on the back of the neck, and we put screws in those two areas and do a fusion to hold that and stabilize it in place. Essentially, like I said, this is what we call, sometimes you'll see in the reports, jump sets. But basically, he had a dislocation of his neck, so cervical dislocation. These are always injuries that require surgery. We basically do a closed reduction in the emergency department, like I showed you. And basically, we only do that if the patient's awake, and we can monitor them neurologically. If they're drunk or inebriated, a lot of times these are often associated with other bad injuries, car accidents, and that's when they have a closed head injury where we can't really monitor neurologically. So then we have to get an MRI, make sure there's no big disc that's sitting in the spinal cord area. Because then you can imagine there's a big piece of disc material sitting there, and then we try to bring his spine back. We can pull that disc material back into the spine and then cause a neurologic injury. And then some people debate whether or not they go in the front and also do an ACDF, but the majority of the time we just go in and put screws in the back and see how they do. So the youngest person in these videos didn't have much velocity, and as you can see, people have gotten faster and faster. This is my co-fellow from surgery or from fellowship here. He's a good old Southern boy. He thought he was going to show me how to get massive air, which he did, and then wiped that over. And the great part about this is about 10 feet outside of the view of the video there, both of our wives are standing there watching him go flying across. So we'll kind of move on down to the thoracic lumbar spine fractures. And basically, in the thoracic lumbar spine, we view these in what we call columns. And we talk about the anterior column, which is in the front of the spine, the middle column, which is the back of the vertebrae. So it's the front, and there's a ligament that runs down here, and it's the front half of the disc space on the body. And then we talk about the back of the body. And then the posterior column is going to be everything in the back. So it's all these ligaments, and there's a bunch of ligaments attached, run up along here, and in between here, there's a ligament also on the inside of the spinal canal. And in general, as you would imagine, most of these injure the anterior column. And the more and more energy that is associated with this injury, the more columns become involved. So that's, the more and more you disrupt going from the front to the back, that's when you start determining whether or not, in general, these are how unstable they are, and whether or not they can be just treated with a brace or you're going to have to do surgery on these. One of the kind of classification scoring systems now that people have developed basically kind of look at one morphology of the injury. So a lot of times you hear it, they have a compression fracture, they have a burst fracture. So all it means is the difference between a compression fracture and a burst fracture really is a burst fracture is when a piece of the bone actually pushes into the canal. Now that doesn't mean that they have any sort of neurologic injury from it. It just means that that piece of bone is now pushing the canal, and so that just says it's more unstable. So they go from having 1 point to having 2 points. And then we look to see if there's any rotational or translational component to it. So has one of those vertebral bodies slid over the other one, or has it slid to the side, or are all the, when we look at the x-rays, is it rotated? And so obviously if it's starting to move forward or backwards, it's going to be a lot more unstable. And if it completely distracts, and then we oftentimes see what we call like a flexion distraction injury, where their spines are bent forward. Now they've completely torn all the way to the back. Those ligaments in the back now are not stable. So if the front of the spine is fractured and it's kind of compressed like this, it's okay because those ligaments in the back kind of perform like a little belt suspenders action and don't let it continue to fall forward. But once you disrupt the back column, those ligaments in the back, now there's nothing to stop it from continuing to fall forward, and that's when they're really unstable. And that's when we decide that we have to do, usually have to do something surgical. Also, we look at their neurologic status now, and so you get a couple points if there's a nerve root injury. So if only one of the specific muscles that is weak when you test it. And then you start looking if there's actually truly a spinal cord injury. And then like I alluded to earlier, this is really where the bread and butter is in terms of describing or determining if we're going to fix something surgically or not. Because as you can see here, they get 3 points if the posterior ligamentous complex is injured, the back of the spine. And so that, you can have a couple points here and there. Once you start injuring the back, that's when we really look at fixing this. Because once we get a score of 5, it's typically when people start talking about fixing something surgically. So this is actually a guy, it was an Amish builder I saw last year. And he fell off of one of the foundation walls. And he has a little fracture just at the end plate there. And you can see there's a little crack that's coming through there. So he's got a compression fracture. So he just gets 1 point for that. And then he has one here. But if you look, everything in the back is all nice and lined up. So this is a very stable fracture for him. Okay? And we still got an MRI just to make sure there's nothing else going on. So you can see this just lights up a little bit of edema. But all the ligaments and everything are all okay. So if this is all torn back here, this is all light up with a bunch of fluid like you see here. And so this guy, I was actually able to just put him, leave him without a brace, because when you're doing small compression fractures in the thoracic spine, your rib cage is there to kind of really help stabilize you. And so for a guy like this, with minimal fractures, we have to limit what he can do from a work standpoint in terms of how much he can lift and things like that. But you don't have to go through the expense of a brace and it being cumbersome for him. So like I said, anterior column injuries are just these compression fractures. Thoracic ones are usually going to be stable to the rib cage there. In general, we get them into a TLSO, and somewhere between 6 weeks and 3 months, we brace them. And unfortunately, this is kind of a judgment call in terms of how long we need to brace them. Obviously, the ones that are more compression, where the body's squished down more, we brace those for a longer period of time, especially if they have continued pain. If they are feeling great at 6 weeks, then we can be a little more aggressive in letting them get out of the brace and start doing some therapy, things like that. But in general, I don't let them lift more than 10 pounds for 6 weeks, and then from 6 weeks to 3 months, I'll usually let them lift up to 25 pounds. And then after the 3 months, when everything looks healed and the x-rays are stable, then we can really get them going. But it doesn't prevent them from doing desk work or other jobs like that. So this is a gentleman that actually fell from the scaffolding. So this is what I was talking about when we talk about burst fracture. So it's still a compression fracture because he fell, and so he's compressed down. But there's so much energy that this piece of bone actually pushes into that canal. This is where all the nerves live. And this is where you may see on the reports, they say something about there's retropulsion or something. So that's what a burst fracture looks like. So if you get an MRI, you can see how it pushes there in the canal, and it's kind of squeezing the nerves. And then you get them into a brace, and it's pretty collapsed there. And so that's kind of a mild burst fracture. And then you have one that's like this, where it's completely, basically obliterating the canal where the nerves are. You can see this piece gets really pushed back in the canal. So now this guy's nerves only have this much space to live with. And then not only has that so much injury that now he's broken in the back of the spine of the canal. And so you know that these ligaments and stuff that are living back here are injured. And you can see there's a tear in the translation of things that kind of come back through here. So now he's disrupted all 3 columns of the spine. So this is a very unstable fracture. And then here's also another one, another burst fracture, not so much retropulsion, so that not too much in the canal. But, I don't have a very good picture, but he also kind of broke out along these pedicles. And so that one's also a fairly unstable one. This was a great story because, have you seen those raccoon suits that people go flying around in?
Oh.
Yeah, this guy was actually he was an instructor on how to do it correctly. Shows you how safe these things are. So, like I said, reverse fractures involve the anterior column and the middle column. So now you're affecting the back of that vertebral body, and some of them actually go on to involve the back of the ligamentous complex. So again, pretty much all of these are going to get braced. They're all going to be in a TLSO for 6 weeks, up to 3 months. And obviously, the more unstable ones, we put them in for more for 3 months. No lifting more than 10 pounds for 6 weeks, and then maybe up to 25 pounds, depending on how stable the fracture is and how well the pain is. And sometimes surgery at the back of the spine is involved. And this is typically what we'll do. So if things are really compressed down, and that bone, we feel we can't allow it to help provide support, we go in and actually do a 2-stage surgery. You go in, you take out that bone, you put a big cage in here, which is what we call an expandable cage. So you may have had patients that had one of these. It goes and it fits in there, and then there's a screw mechanism that allows it to expand and compress and push up against those two end plates, the vertebrae. And then we go into the back and put screws in there to hold it in place. Other times we can, if it's not too unstable in the front, we can just go in, we can do everything from the back. I typically try to get a screw into at least one of the pedicles into the fractured vertebrae, so then that way it helps you control things from a rotation standpoint. And sometimes, these patients have so much energy and stuff involved that they have pelvic or acetabular fractures to be involved in too, that have to get fixed. And the trauma guys, we often have to work with. I was hoping Kaiser was going to be here for this one. This was a fracture. I actually saw this gentleman literally a year ago, and I was just thinking about him because I saw him in the office the other day. He was picking apples for the Johnny Appleseed Festival at 75 years old, which he shouldn't have been doing up on a ladder. And he has this T4-5 fracture dislocation. As you can see, nothing, he's got this big step in the front of his spine. And then these joints, where they're supposed to be nice and lined up, there's this big gap here. Thankfully, he didn't have any sort of neurologic injury, but you can tell as I'm talking. So now he's disrupted the ligaments in the front, also in the back, and these joints are not lined up. So unfortunately for him, he ended up having to have surgery. And basically go and we stabilize the spine by putting screws and rods in there to hold it all in place. Typically with these, because these are really true all ligamentous injuries, like for this one. So there's no bone to kind of rely on to heal. So that's why we can't really say, oh, we can just treat them with brace, because the ligaments aren't just going to heal on their own. And so we have to go in and we have to put in screws at least 2 or 3 levels above and below to help stabilize it. We still put them into a brace. And unfortunately, any spine fractures that go above T5 generally get into what we call a CTLSO, so it's a cervical thoracic lumbosacral orthosis. And patients hate these because these are truly like torture chambers. And these things go, it's a C collar and a TLSO. And it's miserable for people. So if I can, I try to avoid it, but sometimes we can't. This was my first operative case I did when I got here a year ago. And this was a lady who was wrestling with her boyfriend. I don't know what they were doing when they were wrestling, but as you can see, he did something to her because she's got this big fracture here. She's completely torn through everything here. And so here's her MRI, and she's torn everything through here, and then you can see all this lighter stuff here, and that's all edema from those ligaments being torn apart. And you can see here there's ligament, and then nothing, and then ligament again. So she completely disrupted everything. And so for her, she had to have surgery, it had to be fused to stabilize everything. Thank you. Any questions?
Is there a certain condition or at one point that you will say, okay, this needs a neurologist or a neurosurgeon attention, not mine?
For me, there's really, there's nothing that I don't feel comfortable, handling versus a neurosurgeon, especially from a trauma standpoint. sometimes when you start talking about tumors and things like that, when it's a tumor in the spinal cord, that I don't handle, that's not a work comp thing, so usually it's not. But in terms of any other spine injuries, there's not much else other than it is completely shredded all the nerves. Then, I'm going to call in a neurosurgical colleague just to kind of show the cord that, how badly it's torn, something like that, just for somebody else for an opinion just to say, this is how bad it is. Yeah.
Vertebroplasty, kyphoplasty, or any of those concussion factors?
So typically with a burst fracture, kyphoplasties, vertebroplasties generally aren't very safe to do because of the fact that, as you saw, that piece of bone is pushed out. And so that cement, when you pressurize that bone, cement can then leak in. And, you can imagine it would be good to have cement around, the spine and nerves and things like that. For mild compression fractures, I'm okay with it. I generally try to treat people in a brace first and give them the benefit of the doubt as opposed to exposing to a surgical procedure because there are risks with doing the vertebroplasties and kyphoplasties. There are reports of, because especially if they're older patients, when we get older, the bone structure inside, we have less and less bone. And so it gets filled with basically more of blood vessels. And you're going in there and you're pressurizing a bunch of cement, and that cement can find its way throughout the blood vessels. And there are reports of, them putting in cement in the bone, and it ends up in somebody's heart or somebody's lung or someone's brain. They end up having a stroke, or basically have a pulmonary embolism because of that. And so, we do a lot of vertebroplasties, a lot of kyphoplasties, but they're not without risks. And so I would try and brace them first. If I can control their symptoms, then if I can't control symptoms, then maybe that. But for the most part, especially traumatic ones who are especially younger patients, 20s, 30s, 40s, construction workers and things like that, just the brace and time is all they need. Yeah.
On that last one was a 26-year-old resident. Was that an ER presentation, or how did she get to you?
Yeah, she came into the ER. And I got several great hearers with her. Because, I see her in the ER and she's like sitting there and she's like telling me she can't sit still. So she's like stretching her legs and like all this stuff. I'm like, you're going to paralyze yourself. But yeah, she came into the ER. She had whatever they were doing stopped and they called an ambulance and brought her in. Yeah. I can't imagine walking in with that, but yeah. Any other questions?